Welcome to the ANEW Insight Podcast, empowering and inspiring your journey to optimal health. Hosted by Dr. Supatra Tovar, clinical psychologist, registered dietitian, fitness expert, and author of Deprogram Diet Culture. Rethink your relationship with food, heal your mind, and live a diet-free life. I follow my guests' journey to optimal health, providing you with the keys to unlock your own wellness path. Tune in and evolve with us. Hi, welcome to the ANEW Insight Podcast. I am so thrilled and excited to have licensed clinical psychologist and addiction and trauma specialist, Dr. Kenneth Skale, with me today. Hi, Kenneth. How are you?
I'm doing well. Thank you for having me.
I have not had much of anything in terms of addiction in my podcast, and I really wanted to explore this with you today. So I'm so glad you're here. And I'll read a little bit about Ken, everybody, and then we're going to dive right into all of these questions. Dr. Kenneth Skale is a licensed clinical psychologist specializing in addiction, personality disorders, and men's issues. He earned his doctorate from the Chicago School of Professional Psychology in Los Angeles and completed his pre-doctoral internship at Canyon Ridge Psychiatric Hospital. Dr. Skale has since worked in residential and outpatient settings and completed a 2-year postdoctoral fellowship in psychodynamic therapy at Rose City Center in Pasadena. And I love Rose City. It's a wonderful place. Dr. Skale is the founder of Pasadena Healing and also works with the Psychological Care and Healing Center in Pasadena. In addition to his clinical work, Dr. Skale has taught as an adjunct faculty member at Pepperdine University and previously served as the president of the Los Angeles County Psychological Association. And that's how I met Dr. Ken. Known for his integrative whole person approach, Dr. Skale blends deep psychological insight with practical tools for recovery, helping clients break free from destructive cycles and build more meaningful, connected lives. Dr. Ken, thanks for joining me.
Thank you. That's quite an intro. Now I'm pumped. Let's do this.
Exactly. Well, I love to start every podcast with a little bit of inspiration. I really am interested in how people have found their path to what they're doing today. So, what first inspired you to pursue a career in psychology, and then what led you to focus on addiction and personality disorders?
Well, sure. So I think like many people in our profession, I was always the person my friends talked to about whatever was going on in their lives. And so that's been pretty continuous since I was young. But even my own experiences in therapy, beginning at, I think, 8 years old, gave me kind of the patient's view of what talk therapy could do, how it could be helpful. And throughout different periods of my life, it's made a huge impact on me and helped me work through some things. And particularly as I was just about to finish high school, I went back for another course and I had a profound experience that made me switch my major from business to psychology right before undergrad. And I never looked back. So that really was my trajectory into the field.
Do you want to talk about the experience?
Sure. At the time, I was dealing with an aspect of OCD that are these somatic compulsions. So people can probably relate to this portion of it. When you go up in an airplane and you feel the pressure change in your ears, and it can be really painful and uncomfortable. Well, a lot of people don't know that can happen even when you're not changing elevation or pressure. It can actually happen as part of an obsessional element of OCD. And so I would just be going about my life and one side of my ears would begin to feel pressurized and very painful. And it was so annoying because you try to, drinking water can help you, or you just try to kind of pop your ears somehow. And it was really disruptive. And there was one session I had with my therapist at the time, who's an outstanding clinician. And it was actually an interpretation she made to me. And then it was gone. She connected two things that I was kind of in conflict about internally. And from that moment, it never happened again.
Oh my
And
gosh.
that blew my mind. And so that was the moment where I was driving home. Okay, I'm no more going into business. I'm going into psych all the way. it really did leave a mark on me, and it kind of showed me that there's a lot more going on underneath the hood than people realize.
Oh, absolutely. Wow. So then, no looking back from there, that experience was profound. And I think a really clear example of how our problems with the way either we're thinking or trauma that we've gone through or anything that's happening kind of on the mental side can show up in us physically. And I think for so long, people tried to think that or say that they were two different things and one didn't
Mhm.
affect the other. But absolutely, this is a clear example of, having something, whatever it was, affect your physical functioning. And once that clears, then your functioning improves. That's
Yeah,
incredible. Wow.
yeah,
Well, how
yeah.
about addiction? What led you toward that? Working with personality disorders. You were in the psychiatric hospital setting, so you do see a
Mhm.
lot of that. Was that the main reason?
No, this happened right at the beginning of my training. So a lot of people who wind up in addiction work have struggled with addiction themselves. That's not my story, but it's not so much getting into the field of addiction. It's kind of how I wound up there.
Mm,
So in my school, when I was going through picking practicum sites, they our training program only allowed you to apply to certain sites. And it was to make sure students had an equal shot at getting something. And the site that I was allowed, that was the most competitive that I was allowed to apply to, was a methadone clinic that also did
mm,
therapy. And so I applied to that, was accepted, and spent a year showing up at 5 a.m. with folks who, if your listeners have not heard about methadone, it's an opioid replacement. So instead of going through agonizing withdrawal from opioids like heroin, fentanyl, those sorts of things, Vicodin, they take this medicine instead every day that staves off the withdrawal, prevents addictive behavior, and it helps them slowly ease off of the physical dependence. But that means that when they show up at 5 a.m., they are clamoring for their dose. And the way that this clinic was set up was they had to do therapy first. And so at 5 a.m., I was showing up talking to people who were itching to get their medicine. So, not the friendliest environment for my first practicum, but I fell in love with it because I got to hear and meet some incredible people and really get to know the stories behind the folks who were walking in and found themselves in that situation. And I developed a comfort with that kind of situation. And so ever since then, in subsequent practicums, internship, fellowship, in practice, whenever an addiction, where someone struggling with addiction would get referred in, they would often get sent to me because of that experience. And it just compounded to eventually, after I graduated, working at an intensive outpatient program for 4 years, starting out as a clinician, advancing to program director, all focused on addiction work.
wow, that's really I can't even imagine a practicum starting at 5 AM for one in a
It was
methadone
special.
clinic. Yes, that is like, you weren't just dipping your toes in, you're, like, jumping
Mhm.
completely into the deep end, which
Right.
I'm sure just helped to hone your skills and really gave you insight, very clear insight into the nature of addiction. So I think a lot of people get confused. There might be like a blurry line, like I partake in this, but I'm not addicted. How do you define addiction, not just in terms of substances, but in terms of behavior as well? And how would somebody know if they are actually experiencing an addiction?
Mm. I think there's three components to that. Everybody tries at least some drugs or alcohol. Obviously, everyone has probably gambled at some point in their life. Most people have at least tried porn a couple times. Everyone tries just about everything, but there are a select few for whom it sticks. And this is the first component, is it comes to fill an emotional role in their life. So whatever it is, if it's alcohol, if it's food, or pornography, it begins to soothe or meet an emotional need. It could be many things, but that becomes a very well-worn groove. And then every day or regularly, it's something that they're doing to self-soothe or get through the day. The second piece is impairment. So, I mean, I certainly probably would meet the criteria for dependence on coffee. shamelessly to admit that.
What?
I don't think,
Oh.
right, right. I'm in good company. So I don't think that this little guy actually impairs my life very much. Yeah, it's a cost that's relatively minor. It takes some time. I could be being more productive than walking up to my coffee shop 5 minutes to refill halfway through the day, but it's relatively minor. I would say impairment is the second thing. People can either get themselves killed, seriously hurt, really wreck their lives with different sorts of compulsive behaviors. And so that would be the second piece. The third is, I think it's what you'll often notice is if someone is engaging in something that they know is not great for them, like say it's more of a bad habit or something, they can be pretty open about that. They might even joke about it. They'll be transparent. If someone in the back of their mind knows this is something I don't want to give up, I don't really want to take a hard look at it, they will do all sorts of things in conversation to not really look at it clearly,
Mhm.
whether that's minimizing its impact, reporting less than they're usually using, even just managing to not think about what it's doing to them or what they're losing. That's a common thing. And so I would say if it's filling an emotional role in your life and that's been sustained over time, it's causing impairment and you are loath to take a clear look at that.
Yes.
That's a big red flag. All those.
Yes. That's what I see with clients that I've treated for substance abuse, pornography, food addiction, that it starts with some need to self-soothe, some need.
Mhm.
Whatever the cause is, a lot of times it's trauma in their past. It can be anxiety over, just even adulting and just not really feeling like you have total control over that or know what you're
Mhm.
doing, a lot of imposter syndrome. So there's the myriad of reasons I think that people then start to self-soothe, and then that becomes the thing that they rely on, the crutch.
Yeah.
That's what eventually causes the impairment. Then they know that they should stop, and so that's when the cognitive dissonance comes in. If they're not ready to stop, they're going to do whatever it takes to kind of explain it away. Well, I need that break, or, this is actually good for me, or, this helps me XYZ in my life. How do you get people past the cognitive dissonance? That is, I think, the most challenging part of it, especially when you kind of look at it on the motivational interviewing scale when they're just like, I don't know if there's
Mm.
really a problem. So, how do you do that?
Anyone who winds up in your office is usually at least ambivalent. They're torn
Yeah.
about it. And so I think that you mentioned motivational interviewing. It's a great frontline way to engage people. And it's not something, despite the name, it's not some real encouragement to change behavior or whatever. It's a genuine exploration of the conflict within them.
Mhm.
And I don't, outside of some rare circumstances, I don't take a very firm stand on what they ought to do. My curiosity is in helping them feel understood and then helping them reckon with the part of them that really wants to keep doing it because it is doing something for them. It feels judged for
Mhm.
doing it. At the same time,
Mhm.
reckoning with the part of them that knows it causes a problem, or at
Mhm.
least it's damaging the way that other people view them, or it's damaged their financial situation or their health. And the more you can get someone to sit with both aspects, more often than not, people choose to make a change. Sometimes they don't.
Mhm.
But the idea is over time, they'll eventually be put in so much internal conflict as opposed to hearing from their family members or their primary care physician, this is a problem, you need to stop. Then those people take on the role of, you should stop. And person is left with just the part of them who wants to keep going. But if
Yeah.
you can give that concern back to them and just help them explore both sides, that conflict will usually tip into change.
Yeah, that's what I've seen, especially in my work with food addictions, but also in the other areas of addictions. So let's get into the weeds a little bit more.
Mhm.
Talk about some of the different types of addictions you treat and how behavioral addictions like gambling
Mm,
or compulsive eating compare to, say, like substance related addictions.
Good question. So first, in my practice, since it's outpatient, primarily treat alcoholism, a lot of weed use, some amount of cocaine, and more these days, hallucinogens. So like LSD, mushrooms, things like that. In my past, when I was working in IOP and in hospital settings, you'd see more methamphetamine and opioids, heroin, fentanyl, but not so much in the outpatient. I have some people who struggle with that, but they've been to rehab and are stabilized, and now they're coming to work on the underlying struggles.
Mm.
It's a great question about what's the similarity and difference between a behavioral addiction and substance related. The biggest difference is that with a behavioral addiction, for the most part, you don't have a physiological withdrawal syndrome. So I mentioned opioids earlier. If you can imagine the worst flu you've ever had, like say some people got COVID pretty bad, imagine that, but times 2 in terms of the nausea, the body aches, the shivering, the sense of panic. That's what opioid withdrawal is like.
Wow.
And so it's very difficult to just go cold turkey off of something like fentanyl because you feel like you're going to die, even though you won't. There are also certain substances where there is a risk of mortality upon acute withdrawal. So alcohol, benzodiazepines like Xanax, Klonopin. If you are using those in high amounts over a period of time and then abruptly discontinue, you could have a seizure and actually pass away or suffer some pretty serious neurological consequences. And so that's the biggest difference, is that substance dependence comes with these built-in biological risks. And also, I mean, I think some substances are more intense than others. No one's ever, that I'm aware of, actually passed away from smoking too much weed acutely. You can die from a heroin overdose. You can have a heart attack from way too much cocaine or methamphetamine. And so I think there's an inherent more risky element in that way. The ways that they're similar, though, I think is not discussed enough and is very important. Are you familiar with a guy named Jaak Panksepp?
No, I'm not.
He's a researcher. Unfortunately, he died a few years ago, but he wrote this remarkable book about 10 years ago or so called Archaeology of Mind. And anyone who's watching who is in the field of psychology and interested in any sort of work in addiction should probably go read that book. It talks about a number of things, the most important of which is called the seeking system inside of us. It's this neurological system that's below your limbic system in something called your midbrain. And it's literally the capacity to become excited and motivated to go get things. So when you're hungry, when you're lonely, when you have an interest in something, that feeling of excitement, like you're going to go find out, you're going to open a present and see what it is, you're feeling that motivation to go work hard and earn and achieve, that the capacity for that feeling is the seeking system at work, and it's all mediated by dopamine.
Right.
So a lot of what people understand as what they call the dopamine reward system is not quite right. There's this idea out there that, let's say whatever drug it is, let's say it's alcohol, that when I go drink, I get a reward of dopamine and that's why I do it. That's only true maybe the first or second time, at least to any real intense degree. After that, it's not a new experience anymore. It's actually the act of going to get it and doing it that is rewarding in itself. So I'm not sure if you've ever experienced this, but there are some times where I want to go get coffee and get in my car, be driving to whatever coffee shop, be thinking about what I want to get. And I'm getting more and more excited as I'm getting there. This is a positive, energizing feeling. And I get there, I wait in line, I walk up to the counter, and I don't want anything. It's actually the excitement of going to get. And so for a lot of people, especially if they're in any sort of addictive pattern, whether it's food or drugs or otherwise.
Shopping.
What's up?
Shopping.
Shopping, absolutely. The window shopping. You don't have it yet. You're just acquiring and seeking. That's the addictive component. And so I think that underlies substances, food, shopping, gambling, pornography, anything where you find yourself unable to stop, repeating it despite knowledge of negative consequences.
Wow. So let me get this straight. It's the seeking that releases the dopamine. It's not necessarily the
Yes,
substance or the behavior.
right. Right. The behavior initially, when it's a new experience, provides a huge surge of dopamine. So we remember it. Oh, this was a positive experience. But now, anytime I'm stressed, my seeking system activates and I feel motivated and energized to go towards this thing.
It's almost
Even though, let's say, getting high might feel good, there is so much excitement and gratification in the ritual as you prep to get high, whether it's preparing whatever drug, making whatever food, going to the casino, whatever it is. That whole process is exciting and stimulating in itself. Because if it was just at the end result, I get something, it would be miserable going to pick up whatever you're going to pick up. But it's not. The whole thing is exciting, and that becomes the addictive process.
totally. I was gonna say, I don't know if you saw, there's an Apple TV show called Physical. It has Rose Byrne
Mm,
in it. It's about a woman who's embarking on trying to become like the next 80s fit,
mm,
aerobics star, and she struggles with bulimia nervosa. And it's so interesting, her reward-seeking behavior that she embarks on before she has a binge. She visits like 7 different fast food restaurants, rents a hotel, lays out the food on the bed, gets naked to eat it. It's just bizarre, but then that's her ritual to do that. So I can imagine that that's very similar to what you're talking about. And some of my clients who say struggled with porn addiction, there is like there's a ritual
mhm.
before they get set up to do what they're going to do. That is so fascinating. I really, I'm learning a lot. So, hey, distinguishing between a bad habit and a full blown addiction, it has to carry those three parts. Is there anything else that really, kind of sets it up instead of being a bad habit as a full blown addiction?
A big one would be, in addition to the three that we talked about, right? Filling an emotional function. I think a big one would be inability to stop despite negative consequences. So if you have a bad habit and you can kind of talk about it freely, maybe it's a guilty pleasure, but it's starting to cause you problems, you can probably stop. If
Mhm.
you're unable to, now we're into the territory of this is an addictive behavior, probably
Mhm.
because it was filling more of an emotional function than you realized.
Mhm. So,
Yeah, go ahead.
would you say that resolving the addiction really requires resolving what led them to self-soothe in the first place?
I would. So
Mhm.
I think that's I think an important question, maybe one that there's not so much disagreement about now. I think maybe in the past, different decades ago, there could be a lot more focus on behaviorally controlling addictive behavior. I think now it's pretty well accepted in the field of psychology, in AA, any real field you go to, that the underlying emotional issues need work as well.
Mm.
Yeah.
I once saw someone give a talk, and I thought it was really interesting. And he proposed that the nature of addiction and substance use, it stems from a lack of social connection in some way or another. What do you think about that statement?
I would say that's the tip of the iceberg. Can we talk about trauma a little bit?
Yes, of
Would that be
course,
helpful?
please.
Okay.
Absolutely. Well, it's like
Psychology podcast.
it's
Let's
big.
talk about trauma.
Yeah, and it's a big part of what leads us to addiction. So absolutely.
Yeah. So one of the types of trauma that's most implicated in addiction is called attachment trauma. So you ask about social relationships. So attachment trauma is during the critical process of someone's very early years, 6 months old, up to 3 years old, even 4 years old. There's a very important process of bonding and feeling attuned to by parents, where when you have an emotional need and you cry out or you come to your parents, they're able to reasonably quickly intuit that need, not perfectly, but reasonably quickly, figure out what that is, respond appropriately, help you understand what your feelings are, regulate yourself, get you what you need, and you develop an understanding of your own of your own feelings and ability to regulate those feelings. But also, you just develop basically your whole self can feel welcomed. So there's no part of you that is unacceptable. If your parents are, even if you're angry, if you're needy, if you're a little kid and you're crying, if your parents can be reasonably open, again, every parent gets frustrated. I get frustrated with my kids on occasion, but if you can be reasonably open, that kid learns all of me is welcome. One of the issues that can happen is when parents are overly frustrated with their kids or respond in a sort of critical, cold way when the kid is upset or crying or what have you. The kid learns that because of the importance of the bond with the parents, the kid learns this part of me, this feeling I have is a threat to the bond. And so I need to do away with this feeling. And that might be through repression or many other, we could say, defense mechanisms that people use. And so what that means is that as they grow up, then they encounter anxiety about their own feelings because their feelings are a threat to the bond with others. So in that way, when you ask about social connection as a cause of addiction, or social disconnection rather, I agree with that. But deep down, it's because they don't feel like all of them is welcome with others. So when someone's going through a hard time and actually, or is angry or sad or lonely or humiliated or whatever, and that's when they need the social connection most of all, that's when they would withdraw. That's when they don't share. That's when they appear fine, but are actually suffering internally.
Yes.
And that, what is a non-judgmental, always available, predictable source of support is a substance or whatever else we're addicted to.
Oh my gosh. Nail on the head. Absolutely. And I do work from an attachment lens as well. And I think it's so important for all of us to go back and just analyze, just look objectively at our childhood, especially if we are suffering with an addiction, and to see what might have happened. Maybe it's even later than 3 and up. There's a lot of breaches that can happen at different times in their lives. Like one of my clients had one when he was an adult, and it was really traumatic for him and led to him having difficulties with substances. And so it's very important, I think, to analyze that and to find ways to achieve safety in your own self and your body. And we're going to talk about that. And we're also going to dive a little bit more and back and forth. A kind of controversial addiction, I think, is food addiction, and try to make some sense out of it in the next half. We're out of time in this half, but Dr. Ken, you're amazing and a wealth of information. And I am so excited that you joined me for this half. And I'm really looking forward to the next half.
This has been fun. I'm excited for the next half.
Yay. So thank you all for joining us. Tune in next time for the second half of this amazing interview with clinical psychologist, addiction and trauma specialist, Dr. Kenneth Skale. Thanks for tuning into the ANEW Insight Podcast. Please remember, the contents shared on this podcast is for entertainment purposes only and does not constitute medical advice. You can find us anywhere podcasts are streaming, on YouTube at my.anew.insight and at anew-insight.com under the ANEW Insight Podcast tab. And follow us on our socials at my.anew.insight on Facebook, Instagram, TikTok, and Threads for more updates. Tune in next time and evolve with us.